Good afternoon to all. I would like to thank the audience for connecting to this educational webinar. I also appreciate the efficient support of the organizers of this webinar, Professor Maurizio Cutolo and Dr. Emanuele Gotelli from ERN ReCONNET Education and Training Group. My name is Marzena Olesińska. I will moderate the meeting. I'm a coordinator of ERN ReCONNET MCTD disease group. I'm a rheumatologist from Poland. And today we have the honor to guest two experts on connective tissue diseases who are members of the European Reference Network on Connective Tissue and Musculoskeletal Diseases, ERN ReCONNET, Professor Silvia Bellando Randone and Dr. Agata Matusiewicz. Professor Silvia Bellando Randone, please Agata, change the slide, is a rheumatology specialist in Department of Experimental and Clinical Medicine, University of Florence, and Division of Rheumatology, Scleroderma Unit, Careggi Hospital in Florence, Italy. Since 2022, Professor Bellando Randone is a member of ERN ReCONNET. Her fields of interest are systemic connective tissue diseases, especially systemic sclerosis and MCTD. And Dr. Agata Matusiewicz is a rheumatology specialist in the Department of Connective Tissue Diseases, National Institute of Geriatrics, Rheumatology and Rehabilitation in Warsaw, Poland, since 2016. Since 2022, Dr. Matusiewicz is a member of ERN ReCONNET and a member of Polish Society of Rheumatology. Her fields of interest are systemic connective tissue diseases, polyautoimmunity, and management of pregnancy in rheumatic diseases. And now, I'd like to present some housekeeping notes. The webinar will be recorded and published on ERN ReCONNET's website and YouTube channel. For questions during the webinar, use the Q&A session in the Zoom black bar or use the chat. Questions will be addressed to the speakers after the presentation. Starting the content part of our meeting, I'd like to stress that up to 25% of women start pregnancy with at least one chronic medical condition. Our webinar is divided into two parts. Dr. Matusiewicz will present the principles of preconception care, and Professor Bellando Randone will outline the issues relevant to the proper pregnancy planning by a woman with connective tissue disease. Please, Agata.
Thank you very much, Professor Olesińska. In the first part of our webinar, I would like to present some general information about the preconception care. We know that sexual and reproductive health is fundamental not only for individuals, couples, and families, but as well as for the social and economic development of communities and nations. In recent years, there has been an increasing recognition that achieving good pregnancy outcomes is strongly influenced by women's health status, lifestyle, and medical history prior to conception. That is why in February 2012, the World Health Organization and its partner organization have met to achieve a global consensus on the place of preconception care as a part of an overall strategy to prevent maternal and childhood morbidity and mortality. They have proposed some actions to support countries in establishing a system of preconception care. According to the definition adopted by World Health Organization, preconception care is the provision of biomedical, behavioral, and social health interventions to women and couples before conception occurs. The aim of the preconception is to improve health status and reduce behaviors and individual and environmental factors that could contribute to poor maternal and child health outcomes, and to improve maternal and child health outcomes in both the short and long term. The main goals of preconception care are screening for risk, health promotion, education, providing interventions to address identified risks that may affect the future pregnancy. The preconception care emphasize the need to focus on improving women's and men's health before conception instead of just during pregnancy. It's changing the perception of care from healthy mother to healthy babies to the one that focuses on preparation to pregnancy. Preconception care has a positive impact of a range of outcomes, including reduction in mortality and improvement in health outcomes of mother, of neonate and child, the reduction of the incidence of too early and too frequent pregnancies and abortions, and finally, to improve the nutritional status of mothers and women. There is a widespread agreement that to reduce maternal and childhood mortality and morbidity, proper continuum of care should be provided throughout pregnancy, childbirth, the postnatal period, the childhood and adolescence. As we can see on this graphic, the proper and adequate continuum of care should be addressed not only for pregnant women, but it should be addressed to teenagers, young women, and women before and after pregnancy. Here we have the 13 major risk factors which were defined by World Health Organizations. This factor affects maternal and child health outcomes, and they should be of special attention in preconception care. They are nutritional conditions, vaccine preventable diseases, genetic conditions, environmental health, infertility or subfertility, female genital mutilation, too early unwanted and rapid successive pregnancy, sexually transmitted infections, including HIV infection, interpersonal violence, tobacco use, psychoactive substance use, and mental health. But why do we need a preconception care? The results of various reports in recent years present disturbing data. Almost 40% of women report that their pregnancies were unplanned. Perinatal deaths are 50% higher among babies born to adolescent mothers. Maternal undernutrition and iron deficiency anemia account for at least 20% of maternal mortality. Female genital mutilation increases the risk of neonatal death by 15 to 55%. And in the absence of interventions, rates of HIV transmission from mother to child are between 15 and 45%. According to the results of the major survey conducted in England between 2018 and 2019, which involved over 650,000 pregnant women, a large proportion of them was not properly prepared to pregnancy. Even 72.7% of them weren't taking folic acid supplementation before pregnancy. Almost 20% of pregnant women were smoking around conception, and 85% of smokers didn't quit smoking during a year before pregnancy. Nutritional conditions such as obesity or overweight was observed in more than 50% of women, and almost 1/4 of women had at least one mental or physical health condition. The results of the study shows that we still need an education and proper preparation for pregnancy. We know that both malnutrition and obesity before pregnancy have an impact on the course of pregnancy. Too low maternal weight is associated with 32% increase in the risk of preterm birth and a diagnosis of small for gestational age fetus, and may predispose the child to chronic diseases in adulthood. On the other hand, overweight and obesity increases the risk of excessive weight gain during pregnancy, hypertension, diabetes mellitus during the pregnancy, as well as the child macrosomia, large for gestational age babies, and birth defects, mostly neural tube defects. Cigarette smoking is another risk factor for pregnancy outcomes. Fetal effects of exposure to maternal smoking include intrauterine growth restriction, prematurity, low birth weight, congenital malformations, and sudden infant death syndrome. The similar effects was observed in neonates of electronic cigarettes users. They were more likely to be SGA, have low birth weight, or be born preterm compared to tobacco abstainers. Vaping during pregnancy may increase the risk of small for gestational age babies, but there is still a lack of information on this topic. Another risk factor for pregnancy complications is alcohol intake. The consequences of alcohol consumption during pregnancy include increased risk of miscarriage, reduced fetal growth, occurrence of fetal birth defects, mental retardation of the child, and occurrence of fetal alcohol syndrome. An essential first step in woman and man journey to having a baby is taking care of their future pregnancy with a preconception checkup. According to the recommendations from the American College of Obstetricians and Gynecologists, the goal of preconception checkup is to find factors that could affect pregnancy. Among the topics that should be discussed with healthcare professional during the preconception appointment are selected past and present medical conditions, medications and family history, sexual and reproductive health, family nutrition and lifestyle, environmental conditions, psychosocial concerns, vaccines and folic acid supplementation, physical, it is also time to carry out the physical assessment, to clinical examinations, and to order some basic investigations, and to refer for further diagnosis, treatment, and for specialized care if needed. The World Health Organization suggested a number of interventions that should be taken at the preconception visit to improve the future pregnancy outcomes. We don't have time, so I would like to present only some of them. Among the nutritional conditions interventions are screening for anemia, supplementation iron and folic acid, information, education, and counseling about the health lifestyle, about the health diet, screening and treatment of diabetes mellitus, promoting exercise and salt iodization, and interventions for tobacco use are screening for women and girls for tobacco use, providing brief tobacco cessation advice, or pharmacotherapy and intensive behavioral counseling services if needed, screening of all non-smokers, and education about harm of second-hand smoke and its harmful effects on pregnant women and unborn children. The actions for preventing too early, unwanted and rapid successive pregnancy suggested by WHO. It is mostly addressed for state authorities and governments. It's keeping girls in school, creating support for pregnancy prevention programs, education of girls and boys about sexuality, reproductive health, and contraceptive use, enabling adolescents to obtain contraceptive service, and providing the contraceptives to adolescents, and then education of women and couples about the dangers to the baby and mother of short birth intervals. And thank you very much. I would like to give the floor now to Professor Silvia Bellando Randone.
So, good afternoon. Thanks, Agatha, and for your presentation. And now let's move to see why preconception care is crucial in connective tissue diseases. The management of reproductive health issues in patients with connective tissue diseases differ from that in healthy people because, first of all, because disease can impact on pregnancy outcome, as well as pregnancy can worsen disease manifestation. So many of connective tissue diseases have an increased risk of pregnancy loss, adverse pregnancy outcomes, such as preterm delivery and small for gestational age infants and maternal morbidity. But all these aspects may be control, ensuring to patients a controlled disease and pregnancy planning. So preconception care in connective tissue diseases should aim to prevent pregnancy complications, all the ones that you can see here listed, preeclampsia, preterm labor, and so on, but also medical complications such as thrombosis or intrauterine devices associated infection, and the risk flares that we know that is quite common in particular in patients with systemic lupus erythematosus during or after pregnancies, even when disease is questioned at conception. So all these aspects highlight the importance to assess risk factors for adverse pregnancy outcome. And I would like to present you the results from the PRONIS study, that is a multi-center observational study focused on pregnancy outcome of patients or women with systemic lupus erythematosus with or without risk factors. And you can see how the percentage of patients who had any adverse outcome was higher in patients in those who had risk factors such as hypertension or an active disease during pregnancies compared to those who had not. So it is really important, and this underline the importance of pregnancy planning and of risk stratification in patients with connective tissue diseases, and this can be done through a multidisciplinary approach that involves all specialists that work around the connective tissue disease patients, rheumatologists, psychologists, specialists in maternal fetal medicine and reproductive endocrinology and fertility, and gynecologists, and so on. So preconception counseling is really important both for patient and her partner, and should include discussion also regarding the importance of a questioned disease, as well as all the other aspects that can impact in prognosis and the expectation of pregnancy outcome, as well as of the management of the pregnancy. Here you can see the disease activity, disease-related damage, the severity of internal organ involvement is very, very important to assess, because it can be encouraged to choose other ways of having a child. For example, in vitro fertilization or abortion. And it's really important also to assess the autoantibody status and the current recent medication. This validation should be done before the conception, but also whenever, for example, the medication is changed during the disease. So regarding disease activity, I would like to show some aspects. For example, in systemic lupus erythematosus patients, we know that an active disease during pregnancy confer a lower chance of live birth and lower chance of full-term delivery, while greater chance of perinatal death. So it's really important to the timing of the pregnancy and the conceiving. In particular, it is really important that the disease is stable on compatible medication for 4-6 months before the conceiving. Regarding systemic sclerosis patients, we can speak about disease activity, but we can speak about the different subsets of the disease. In particular, literature data show that patients with an early diffuse systemic sclerosis are thought to be at increased risk for developing renal crisis during pregnancy. And always patients with the diffuse cutaneous form with a disease onset less than 4 years might have a higher risk of progression during pregnancy or the postpartum. So this data, this aspect highlight the importance of planning the pregnancy, and in these cases, it should be preferred to defer pregnancy and treat patients and reassess patients when the disease is stable. The end of organ damage is a crucial point, because all of these complications, or someone is something is very, very critical in the prognosis of pregnancy, should be considered carefully, because let rheumatologists think about other way, for example, in vitro fertilization with surrogate or adoption, because confer a high risk also for the fetus, but in particular for the mother, for if pregnancy continues. And another special important issues is the assessment of autoantibody profile, particularly anti-SSA and anti-SSB, as well as antiphospholipid antibodies. Regarding anti-SSA and SSAB, they confer a risk of neonatal lupus erythematosus or transient neonatal lupus erythematosus features, but in particular, the critical point is the high risk of a serious and permanent congenital heart block. For this complication, a periodic fetal echocardiogram and the use of hydroxychloroquine may reduce the risk, in particular, of the complete heart block. Regarding antiphospholipid antibodies, testing them should be performed in patients, particularly with systemic lupus erythematosus or systemic lupus erythematosus-like disease, and in patients with suggestive histories or physical findings. This aspect that is catch from the recent recommendation published in 2020 highlighted the importance of antiphospholipid antibody profile and history, not only the laboratory panel, but also the history of patients may influence treatment and management during the pregnancy. In fact, as you can see here, patients with positive antibodies without thrombosis of obstetric complication require treatment with prophylactic aspirin during pregnancy to prevent complications like preeclampsia in particular. While patients with positive antibodies and with obstetric and thrombotic antiphospholipid syndrome should be treated with low dose aspirin and prophylactic dose of heparin. Here, there is a list of the major risk factors for an adverse pregnancy outcome. You can see that particularly important is the disease activity, in particular for the systemic lupus erythematosus, and that should be stable. Particularly, it is critical if there is a disease activity or a flare in the last 6 and 12 months before or at conception, giving an increased risk for maternal disease activities as well as fetal morbidity and mortality, and so on. You can see here also a complication like lupus nephritis, in particular, not only an active nephritis at conception, but also history of this complication is considered to be a strong predictor of poor maternal and fetal outcomes. And another critical issues is the compatibility of treatment with pregnancy. That is one of the most aspects that should be addressed both during the preconception counseling and at the start of any new treatment, because as you can see here, many drugs that are commonly used in connective tissue diseases are not compatible with pregnancy, so they need to be stopped. For example, you can see here methotrexate 1-3 months prior to conception, or mycophenolate, for example, it should be stopped at least 6 weeks prior to conception, and so on. This is a topic really important in the planning of pregnancy. And the last topic, hot topic, because it's really important in patients with connective tissue diseases for avoiding to have an unwanted pregnancies is the contraception. And the contraception choice depends on the efficacy, on safety, and on individual preferences. But there are still many significant issues affecting this choice and are concerned for particularly the risk of flare, the risk of thromboembolism, and the potential interaction with medication. Here you can see some drugs that have potentially interact with hormonal contraceptive. You can see mycophenolate, cyclosporine, warfarin, and so on. But because of all these doubts, probably, many studies report that patients with, in general, autoimmune diseases, in particular connective tissue diseases, use contraceptive drug less than we would want that they do. Particularly, you can see here that among more than 2,000 women, only 32% use prescription contraception, and only 7% use highly effective prescription methods. But the most interesting thing is that more than 70% of patients were taking at least one teratogenic medication, but this was not associated with prescription contraception use. So this is a question. I would like to raise a question to everybody, because there is a problem probably in the preconception phase, also because rheumatologists sometimes or too often delegate the gynecologist to discuss this topic with the patient because of not enough confidential with this topic, or because of lack of time. And this aspect is required to be changed, because it's really important, also because of the planning of the pregnancy. And the risk of flare is one of the main problem and the main reason, because often patients don't take or prefer not using contraceptive, because even if in the past many data report a high risk of flare, particularly in patients with systemic lupus erythematosus. In 2005, there have been 2 trials that reported not an increased risk of disease flare in patients using estroprogestin, but in reality, we know that women with active systemic lupus erythematosus disease, especially with nephritis, are discouraged from using estrogen, progestin, oral contraceptive drug. And another issue is the risk of thrombotic events. Particularly, we know that the positive of antiphospholipid is the most significant risk factor. But in this case, in the case of positivity, estrogen, progestin should be avoided in patients with positive antibodies or other significant risk factors for thrombosis. While regarding the use of progestin-only contraceptive, they can be considered as a safer alternative than estrogen, progestin for women with systemic lupus erythematosus who have this kind of autoantibodies, or patients with active nephritis and vascular disease. So to conclude, my take-home message are that reproductive issues are of paramount importance for women with connective tissue diseases and should be addressed regularly by a multidisciplinary team since the first examination. And preconception counseling and risk stratification are essential for prevention of pregnancy complications. Contraception and pregnancy planning should be asked at the first visit of early examination or when starting a new medication if all women childbearing age and men candidate to teratogenic treatments. And it's really important to emphasize the benefits of safe and effective contraception in preventing adverse maternal and pregnancy outcomes. Thank you very much.
Thank you very much. Thank you, Agata. Thank you, Silvia. I think that this webinar, this topic is very important. And I think that there are still so many unmet needs to continue the preconception care in proper way. Could you define your opinion? What is the most important, taking into account this general recommendation, what said Agata and what you said, Silvia? Do you remember about all these dangerous things regarding future pregnancy? I thought if we have, as a doctor, if we have good knowledge on all these risk factors, this general, with lifestyle, with tobacco use, do we have these numbers, these some facts that are important, and then we can share with our colleagues, our patients? Do we have it in our mind? Please, Agata, could you comment?
I think that we don't share with those informations with patients, maybe because we don't have time enough on visits. But I think it's very important because patients really want to learn these informations. It's a really important topic for them. And they often ask about the preparation to pregnancy. They ask about the medication they can use or can't use during the pregnancy. I think that is there are a lot of unmet needs in this topic.
Silvia, could you tell us something on this?
Yes.
What you think?
I think that all the risk factors that Agata listed and show up as should be taken into consideration in general practice and put together all with all the other risk factors correlated to connective tissue diseases, because I think that the best result we will be able to achieve considering all these different aspects, all general aspects and aspect disease related. For example, in particular, disease activity, the internal organ involvement, the autoantibodies and so on, but not only, because I think that we need time, we need to learn to spend much more time to discuss of all these things with the patient in order to also listen to them and explain as much as better we can what they can expect, which are the risks, and which are the best strategy that we can decide in order to reduce the risk for the mother and for the fetus, and also to reduce the risk of disease flare, for example.
Thank you. And I want to back to the results of these real life studies presented by Agata and by you, Silvia, from Great Britain, from USA. We can see how poor results are from our learning, our education. The results are rather bad, I think. Yes, Silvia, do you want to comment?
If I think about the study that I presented you, one of the things that quite surprised me is reading that even if a lot of patients were taking teratogenic drugs, they didn't take any kind of contraceptive drug. So I think that probably these aspects should be improved in clinical practice, because it is an important data, because also patients don't take so much contraception, but also patients who are taking teratogenic drugs. So probably we need to spend a few minutes during the visit highlighting and making clearly understand to the patient also that the role and the risk of the drugs that they are taking, I think.
And continuing this issue, I'd like to read the question. Maybe we can continue, Silvia, this. Thank you very much for your talks. In your clinical practice, what do you advise a woman with connective tissue disease who has not planned a pregnancy and becomes pregnant while receiving potentially teratogenic therapy, like mycophenolate mofetil?
Yes, I think that it depends also on the characteristic of the patients and the involvement of all the other internal organs. I think that it's not so easy, say, a general recommendation. Mycophenolate is not allowed during the pregnancy, so it would be necessary to stop it. But I think that it's very important to make a global evaluation of all the aspects of the patient and the risk that they would have stopping the drugs. We can try to change, but not always is possible or it is easy. So it depends on the characteristic of the patient.
Yes.
I think.
And very detailed examination of fetus at their early stages of development by UCG or some other methods. So yes, this is a difficult moment for the mother and for us as caregivers. So but it happens. So we know that everybody should be aware about it. I see that we don't have more questions. Maybe you want to add something or to comment our our presentation. I think that general knowledge about preconception care is still very low in our population. And Agata mentioned about this initiative of World Health Organization. I don't know if you know this initiative, but it was from 2013. And this is a very wide project with the involvement of population, with the involvement of little children, teenager, whole society. And I think that this kind of action can give us some stable, some good effects. This is a good idea, I think. So I think we can finish our webinar. Thank you, Silvia. Thank you, Agata, for your interesting presentation. I'd like to also thank the audience for your time, and please follow our ERN ReCONNET for future webinars. Thank you, everybody.